We often marvel at a medical diagnosis, right?
Mhm.
That moment when a doctor just seems to know exactly what's wrong.
Yeah, it can seem almost like magic sometimes.
But behind that conclusion, there's this fascinating mix of, well, hard science and maybe a surprising bit of art.
Definitely. It's complex.
And for you, our listeners, we know you want to grasp these big topics quickly but properly. So we thought, okay, a deep dive into medical diagnosis is definitely needed.
Absolutely. And we've pulled together some really um, compelling resources to walk through this with you. We'll be looking at the Elsevier Guide, Diagnosis, The Art of Being a Doctor. It really maps out the core skills.
Yeah.
Then there's practical stuff on history taking and exams from University College London, and a really interesting case study from PMC PubMed Central.
Right. And we're also drawing on the NCBI bookshelf for genetic disease diagnosis, Wikipedia's take on medical history just for a baseline, a look at the cognitive challenges in getting good patient info, again, from PMC.
And that last one from Me Desk on why patient demographics are so important.
It feels like a really solid mix.
It is. And our mission today really is to pull the key insights from all of these for you, to unpack how diagnoses are made, the hurdles doctors face, and, how crucial both that deep medical knowledge and the patient interaction are.
So consider this your shortcut to getting a handle on this whole area without needing a medical degree yourself.
Exactly, a streamlined guide.
Okay, so where should we start? Maybe with how the doctor's role itself is changing? It's not quite the solo act it once might have seemed, is it?
No, not at all. That Elsevier guide makes a strong point about healthcare becoming much more team-based. You see lots of different health professionals stepping into roles that historically only doctors did.
And then there's AI, artificial intelligence. That must be a huge factor now, analyzing all that data.
Oh, absolutely. AI can spot patterns in enormous data sets, things humans might just miss. It's a big shift for diagnosis and managing conditions.
But it can't replace everything, right?
Well, that's the crucial point the Elsevier authors make. Even with amazing AI, you still need the doctor for the human stuff. Tailoring explanations, working with the patient on a plan, giving that care and support, empowerment.
Yeah, that makes sense. A computer can give you odds, but it can't really understand your fears or what you hope for, can it?
Precisely. Now, if we shift to the actual diagnostic process, all our sources pretty much agree on one thing, the absolute foundation, taking a good medical history.
It's kind of amazing, isn't it, that Elsevier Guide says up to 80% of a diagnosis can come just from the history.
80%. It really shows that even now, with all the tech, just listening carefully and putting the pieces together from what the patient tells you is still the most powerful tool, often before any tests.
So it's not just about collecting facts.
No, it's way more than that. Elsevier stresses it's how you build that therapeutic relationship, making the patient feel heard, giving them space to talk. That builds trust and respect. It's fundamental.
Okay, so how do doctors get a really effective history? What are the key things?
Well, several things jump out. First, getting the presenting complaint. Like, in the patient's own words, why are they here today?
Right.
Then digging into the history of that complaint, all the details, when it started, how it changed, what helps, what hurts.
So,
And the UCL guide really emphasizes summarizing back to the patient. Okay, so I hear you saying X, Y, and Z, just to make sure you've got it right.
good idea.
And signposting, okay, now I'm going to ask about. And really importantly, using plain English. Avoid the jargon.
Oh yeah, jargon is such a turnoff. It just confuses people.
It really does. UCL even says, don't say drugs if you just mean medications. Then there's family history. That's vital, especially as Elsevier and NCBI point out with younger patients or if you're suspecting something genetic.
So you need the family tree, who had what.
Exactly. Detailed structure, who was affected, any early deaths, that sort of thing.
And it's not just medical stuff in the family, right? Social history matters too.
Hugely. Elsevier explains it does two main things. Helps spot environmental factors, maybe something at home or work is contributing, and it gives you insight into lifestyle. Housing, jobs, smoking, drinking, drugs, travel, even pets or hobbies can sometimes be relevant.
Right, it puts the illness in the context of their actual life.
Exactly. It paints a fuller picture. And finally, UCL reminds us about the systems review, quickly asking about different body systems to catch anything else the patient might not have thought to mention.
Okay, so we have this detailed story from the history.
Mhm.
What about the physical exam? Is that still as critical with all the scans and tests we have now?
Oh, absolutely. Technology's amazing, but the hands-on exam gives you direct information you can't get otherwise. Elsevier suggests starting with a quick feet-to-face look, just 30 seconds for an overall impression. Even looking around the patient's space can give clues.
Like seeing an inhaler on the bedside table.
Exactly. Then you get more focused. Elsevier and UCL detail examining different areas, checking hands for clues like temperature or nail changes,
Yeah.
listening to the chest, feeling the abdomen for lumps or tenderness, checking limbs for swelling or skin changes. Like finger clubbing might point towards lung issues. Specific belly pain tells you something about the organs there.
So it's like gathering physical evidence piece by piece.
That's a good way to put it.
And then come the tests and investigations. When do they fit in?
The key principle, according to Elsevier, is that tests should answer a specific question, not just a routine checklist. And you really need to understand sensitivity and specificity.
Right. Sensitivity finds the yes cases. Specificity finds the no cases.
Yeah.
That D-dimer example for blood clots was good sensitive to rule it out if negative, but not specific enough to rule it in as positive on its own.
Precisely. And Elsevier also highlights thinking about the risks of test radiation, invasive procedures, and talking those through with the patient. Informed decision.
Makes sense.
Plus, how certain you need to be depends on the treatment. You wouldn't start chemo without a biopsy confirming cancer, right?
Exactly. Okay, so behind all this gathering of information, history, exam, tests, how do doctors actually think their way to a diagnosis? Are there different models?
Yes, Elsevier talks about two main ways of reasoning. There's the traditional approach, which connects to what Daniel Kahneman called type 2 thinking. It's slow, careful, logical deduction, ruling things out step by step.
Okay, the analytical way.
Right. And then there's type 1 thinking, which is pattern recognition, quick, intuitive judgments based on past experience, seeing a pattern you recognize.
And the best way is probably mixing them.
Seems like it. Elsevier suggests starting with that quick type 1 impression, but then testing and refining it with the slower type 2 analysis as more info comes in. It's a constant reevaluation.
But you have to be careful with that quick thinking, right? Biases can creep in.
Exactly. Elsevier warns about getting stuck on an early hunch, even if things don't quite fit later, which leads us straight into diagnostic error and patient safety.
Yeah, that figure from Elsevier was pretty sobering. Maybe 10 to 15% of diagnoses could be wrong. That's significant.
It really is. And while sometimes it's lack of knowledge or resources, often it's these cognitive biases, shortcuts in thinking that lead us astray.
So how do you fight that?
Well, Elsevier suggests strategies like consciously running through lists of disease types, like is it infectious, inflammatory, malignant, just to force yourself to think broader. They also mention levels of diagnostic depth. Sometimes a general description is better than forcing a label too early.
Right, sometimes you need to wait and see how things develop. That watchful waiting idea.
Exactly. Elsevier mentions that. It can be useful, especially if diagnostic criteria require symptoms for a certain time. But you absolutely have to discuss it openly with the patient. Make sure they understand why and that you're not just delaying needed treatment.
Yeah.
And sometimes investigation might be avoided altogether, like in very frail patients, or if the patient refuses. It's always a judgment call.
It's such a balancing act, isn't it? Knowing when to push for answers and when to hold back.
It really is.
And while sometimes one test result nails the diagnosis,
Like finding those urate crystals for gout, Elsevier calls that pathognomonic, meaning it's definitive.
right. But often it's more complicated. A combination of things.
Much more often, yes. Like for lupus, you need a whole set of criteria, symptoms, signs, lab tests to meet the diagnosis.
This all just hammers home that being a good doctor is so much more than just knowing facts. That communication piece seems absolutely central. That second article, Are You Listening to Me, Doc? Really focused on that.
It really did. It makes the case that great communication is key for that positive patient-doctor relationship. And that leads to patients being happier and more likely to follow through with treatment. They often judge a doctor's overall skill by how well they communicate.
And it's not just talking, it's listening and nonverbal stuff.
Absolutely. The article stresses active listening, showing empathy, compassion, real caring, and conveying that through eye contact, gestures, posture, facial expressions. Apparently, a huge chunk of communication is nonverbal.
Wow. And the article said a major reason patients are unhappy is feeling ignored.
Exactly. Feeling like they weren't truly listened to, building that rapport makes the doctor more effective, plain and simple.
And better communication leads to better results for the patient.
Directly linked, yes. Better compliance, better outcomes. Now, to really see the power of a good history in action, that case study from PubMed Central about the Cree boy was striking.
Oh, yeah, that was powerful. How a detailed history, especially in a potentially rare case, can be absolutely critical. He initially just looked like he had a virus, right?
Exactly. Common symptoms, non-specific exam. It was the grandparents, who spoke more English, who gave the crucial extra history. They mentioned the eyes rolling back and him being less active, things the parents hadn't initially conveyed.
And that changed everything.
Completely. It suddenly pointed towards a neurological issue, and then the family history piece came in.
Ah, right. The relatives who had something similar.
Precisely. A maternal uncle's child had a similar undiagnosed illness. That, plus the CT scan findings, led them to leukoencephalopathy, a specific genetic condition found in that population.
It just highlights needing to know about population-specific conditions and digging deep into family history.
Absolutely vital in that case, which brings us neatly to genetics in general.
Right. The NCBI bookshelf piece said pretty much all diseases have some genetic link.
To some degree, yes. From single gene disorders to complex interactions, diagnosing them usually involves that same triad: physical exam, detailed family history, and then clinical or lab tests, often specific genetic tests.
And there are red flags in the history that might make you suspect a genetic cause.
Yes, NCBI lists several: multiple family members affected, especially close relatives, history of miscarriages or childhood deaths, common adult diseases starting unusually early in relatives, developmental delays, birth defects, or those subtle dysmorphic features.
And these can show up anytime, not just in kids.
That's right, genetic conditions can manifest at any age.
And genetic testing itself is used in lots of ways now.
Yeah, NCBI covers the range: newborn screening, carrier testing for family planning, prenatal diagnosis, testing to confirm a diagnosis or predict prognosis, and even predictive testing for future risk.
So putting it all together, taking a medical history, sounds like this structured process to get the whole health picture. But the UCL guide warned against being too rigid about the order you ask things.
Exactly. They said experienced doctors often work more like detectives, testing ideas as they go, but everyone needs to cover the basics: the main complaint, the story of that complaint, past medical and surgical stuff, meds and allergies, family history, personal and social life, and that systems review.
And UCL repeated that point. A good history often gives more clues than the exam and builds that crucial trust.
Foundational.
But it's not always easy to get a reliable history, is it? That PMC article about the challenges was eye-opening.
No, it's definitely not straightforward. That article talked about how normal memory just isn't perfect. There's the telescoping effect, remembering things as more recent than they were, and even sometimes false memories.
Wow. And strong emotions can warp memories too. And even how you ask a question can mess things up.
Precisely. Prompting someone can accidentally shut down other memories. There's the halo effect, letting earlier info color how you hear later info. People stick to beliefs even when evidence changes. We want to present ourselves well, which can affect what we share. Even where you are can affect recall context dependency.
So many potential pitfalls just in trying to get the story straight.
It really highlights the cognitive complexity involved.
Okay, one last piece. Patient demographics. Why is that so important? Seems a bit separate from the individual diagnosis.
Well, the MEDISC article explains it's crucial for the bigger picture population health. Authorities use that data for planning services, facilities, training. It feeds into national stats and research, helping spot risk factors in different groups.
Ah, okay.
And on an individual level, knowing a bit about demographics can help with communication, being more culturally aware. It helps tailor the care.
Okay, so wrapping up this deep dive, wow. Medical diagnosis is clearly this incredibly intricate process, so many moving parts.
Absolutely. Technology is racing ahead. AI is changing things. But those core skills, listening carefully during the history, the hands-on physical exam, they're still completely essential.
And it's not just about knowing the medicine, it's about navigating how people remember things, the biases, and really connecting through communication and empathy, understanding the whole person.
Yeah, seeing the patient in their context, their life, their background.
It really throws that evolving role of the doctor into sharp relief, doesn't it?
Yeah.
Balancing the tech with that vital human connection.
Which leaves us with a pretty big question for you to think about, doesn't it? As AI gets woven more and more into healthcare, what will that doctor-patient relationship look like down the road? Will technology actually help doctors be more empathetic, give them more time for connection, or could it accidentally put up new walls? It's definitely something worth mulling over.